Good evening to all of you in India. I am Venkat Narayan from Emory University, and it is my pleasure today to welcome our dear colleague and friend, Dr. Prabhakaran, to give this symposium. And I welcome Dr. Prabhakaran on behalf of Emory University, the Rollins School of Public Health, the Hubert Department of Global Health, and the Emory Global Diabetes Research Center. Dr. Prabhakaran has been a longtime friend, colleague, and collaborator of Emory University, has collaborated on a number of very important studies with a lot of colleagues here at Emory and the world over. He is the Vice President for Research at the Public Health Foundation of India, which is India's premier public health organization. He's a professor at the London School of Medicine, of Hygiene and Tropical Medicine, and also an adjunct professor at Emory University. In addition, Dr. Prabhakaran leads a coalition of 4 schools: Emory University, the London School of Hygiene and Tropical Medicine, Public Health Foundation of India, and the All India Institute of Medical Sciences in a collaboration called 4C, which brings together an international academic collaboration for non-communicable diseases. Dr. Prabhakaran is a cardiologist by training, spent a lot of time in clinical cardiology at the reputed All India Institute of Medical Sciences in New Delhi, and then shifted his career slowly towards population sciences, epidemiology, and public health, and has dedicated his life and career to public health of cardiovascular diseases and chronic diseases in India and in the developing countries. He was one of the senior editors of a very important publication, the Disease Control Priorities, and his editing of the Cardiovascular Disease Volume included extensive assimilation of evidence and advice for policy, and made a huge contribution to the world of non-communicable diseases. Dr. Prabhakaran is the most cited medical researcher in India, as per Scopus statistics, and he has really collaborated in a number of large cohort studies, randomized controlled trials, implementation studies, and has been at the cutting edge of policy and translation. He specifically enjoys mentoring young investigators and has grown a whole number of young investigators in India and worldwide. A number of US investigators have benefited from Dr. Prabhakaran's mentoring. And above all, he's a great friend. And today, he will reflect on the role of global research in the area of cardiovascular disease. As we think of the world today, the United States is about 4% of the world population. India is about 16% of the world population. So when you're talking about a collaboration that involves 20% of the world population with impact across the world. And it is an extremely important collaboration when it comes to global health. And it is not easy to establish collaborations with such long-term focus and with such long distances separating us. And very importantly, the relationship between Dr. Prabhakaran, his group, and Emory University over the past 14, 15 years has really developed a model of extremely equitable and mutually beneficial collaboration, benefiting science, benefiting junior investigators, and benefiting public health at large. So Dr. Prabhakaran will use his experience to talk to us today about what we have learned through this collaborative experiences and exactly how global health and global cardiovascular disease research collaboration contributes to science and to capacity building. Capacity building is extremely important when it comes to global health and to improving the platform for collaboration into the future. With that, I'm going to welcome Dr. Prabhakaran. As you have questions, please enter your questions in the Q&A box. And as moderator, I'll look at the questions and highlight the ones to post to Dr. Prabhakaran at the end of the presentation. Thank you very much. Dr. Prabhakaran?
Yeah. Uh, Thank you, Professor Venkat Narayan. Let me be formal at least once because I always call you Venkat. And so let me be formal here. And thank you and to your team of Mark Hutchison and Evan and others for making this happen. It's a great honor to be giving this talk. And I can't say how much I'm missing being at Emory and talking to all of you. Hopefully by next year, I think this will too come to a pass and we'll be able to travel and see each other in person, although we have been in virtual contact every now and then. In the next 40 minutes or so, I'm going to take you through this remarkable journey of global collaboration over the last 12 to 13 years. In this process, we have advanced the science, we have created a large network and built a huge collaboration. And above all, I think the deep friendship that I've made with many of you is worth preserving for me and worth mentioning. It's been a great journey because of this friendship. Indeed, it's been a lot of fun having this collaboration. I'm going to talk about some of these. Now, one might ask, what would be the rationale for this global collaboration in cardiovascular research and capacity building? All of us know this, and I don't have to emphasize this point, that cardiovascular disease is a global threat. And all global threats need global solutions. We may contextualize the solutions to the local context, but at the upper end, there has to be global solutions. And what happens in India can create, I mean, if we look at the Black Swan event, which has been popularized by Talib, something that happens in Scandinavia can affect India. And similarly, even in terms of global health, things that happen in one part of the world can affect another part of the world. The second is we need global collaborations to develop new knowledge, and we need research to develop new knowledge. The benefits of global collaboration has to be bidirectional, and it also enables us to give mentored research to produce the next generation of leaders and have long-standing relationships. And I'm going to talk about some of these. But before doing that, let me get into some historical perspectives. At the turn of the century, I'm going to misquote Charles Dickens and give you the tale of these two worlds. There have been tremendous achievements both at population and individual levels in the global north. There was a substantial decline in cardiovascular disease mortality. In fact, in UK, for example, there was over a 50-year period, more than 50% decline in mortality. And this was observed within one generation, which is very remarkable. The acute myocardial infarction mortality in the 1960s and 70s was close to 30%. With the introduction of the CCUs and with the introduction of thrombolytic therapy and adding aspirin, by 1988, it came down to 7%. With primary PCI, it has come down to 4% in 50 years' time. And there's been substantial decline in cardiovascular risk factors across the high-income countries. Hypertension has declined. It's only the obesity that has gone up, and to some extent diabetes has gone up, but smoking has come down, hypertension has declined, and many other cardiovascular risk factors have declined. By contrast, in developing countries or low middle income countries, because of uneven prevention policies, we continue to see a rising burden of cardiovascular diseases. The other depressing point is there's huge disparities in care within countries as well as between countries. Even within United States, for example, there are some states where the mortality due to cardiovascular disease is higher than some other parts of the United States. Across the world, lack of simple and essential drugs has been observed. In fact, all of us know that 4 simple drugs can actually reduce mortality and prevent a recurrent myocardial infarction or a heart attack after an index heart attack within the first year. And these 4 drugs are highly inexpensive. But despite that, these drugs are not widely available and not easily available to most people. And there is huge gap between best practices and actual delivery. So the challenges at the turn of the century was that many of these low middle income countries had a double burden of disease. In fact, if you look at India, for example, in the 1990s, the leading cause of death was infectious diseases and nutritional diseases. In fact, cardiovascular disease was number 3. Now it has become number 1. But at that particular point of time, there was a double burden of disease. There was limited research capacity. In fact, in the famous paper by the Global Forum for Health Research, they touted something called the 80-20 principle. 80% of the research happens in countries which had only 20% of cardiovascular diseases. And we also did a paper in 2004 to look at what happened, and it was exactly similar, this 80-20 principle. It is applicable for many other issues, like the biggest effects of climate change and environmental pollution will be in the LMICs, but most of the resources are coming from the high-income countries. And in the turn of the century, there was lack of multidisciplinarities. Doctors were treating the patients and also framing policy. So you really required a multidisciplinary group to look at how to prevent cardiovascular diseases. However, there were tremendous opportunities at the turn of the century. There was a wide recognition that cardiovascular disease is a worldwide problem along with other chronic conditions, and it was also noted that there was the highest burden was observed in the low middle income countries, and there were several international funding opportunities that emerged at that particular point of time. The first paper to come out was in Nature, this simple paper which spoke about grand challenges in chronic non-communicable diseases, actually led to a huge flurry of activity. In addition to that, the Initiative for Cardiovascular Health was established in India with support from WHO and the Global Forum for Health Research, and it produced a seminal monograph called Race Against Time, which was a joint collaboration of University of Sydney, the Earth Institute, and IC Health. And both these actually gave impetus to cardiovascular prevention programs, so much so there are a lot of other groups which came together, such as the NCD Alliance, the World Heart Federation, the International Diabetes Federation, which already existed, but their activities were enhanced. So around 2007 and 2008, United Health and NHLBI decided that they will fund centers of excellence across the world. And we were selected as one of the centers of excellence. There were 11 centers of excellence. And this was a joint partnership of Emory University, Public Health Foundation of India, the Madras Diabetes Research Foundation, and the All India Institute of Medicine. Simultaneously, the Wellcome Trust funded a joint program by the London School of Hygiene and Tropical Medicine and the Public Health Foundation of India called the South Asian Network for Chronic Diseases. And we also had the Center for Chronic Disease Control in India, which was doing multiple projects on prevention and capacity building. In 2014, we thought, why have so many centers, and all these centers should come together, although Center for Chronic Disease Control is still independent. And we forged this 4 joint centers, which Venkat mentioned, which is called the Center for Control of Chronic Conditions. In addition, the Global Alliance for Chronic Disease was launched, and only for the second time in the history, the UN had a high-level meeting on NCDs in the year 2011. So all of this resulted in increased funding and increased awareness, as well as increased advocacy for cardiovascular disease prevention. So what was the situation in South Asia then? I need to emphasize this point again, that CVD was a major contributor to the rising toll of death and disability in India. But the important point that I wanted to make is that it afflicted the younger populations, which means that people in the working age group, people in their productive years lost their lives immensely. A metric which is called as potentially productive years of lives lost gives you an indication as to what the potentially productive, what the impact of this disease was. So the potentially productive years of lives lost in India was higher than the potentially productive years of lives lost put together for US, Portugal, South Africa, Brazil, and China put together. It was higher. Of course, China had a higher stroke burden. There was a high co-occurrence of diabetes, and there was substantial heterogeneity of disease patterns. Like in the south of India, there was more of diabetes and atherosclerotic cardiovascular disease. In the northeast of India, there was more hypertension and stroke. In the middle of India, there was more of rheumatic heart disease, which is a pre-translational disease, and more of strokes again. So there was wide heterogeneity in the cardiovascular disease patterns. I mentioned about the enormous productive life year and economic losses, and there was high case fatality in the long term. We did not know the reason then. Could have been unaffordability, higher risk or compliance issues. But one point that the Interheart study, which was conducted in 2004 and published in 2004, suggested that the risk factors across the world are very similar, but the thresholds at which they operate may differ. And I'm going to show you the example of diabetes a little later. But one recurring theme was the research capacity was limited, there was limited translation, and there were several health system inadequacies. So what was needed? We needed a comprehensive cardiovascular chronic disease prevention programs. We needed a new understanding of the mechanisms of disease. We needed to identify several, and we identified several challenges, including the lack of a good surveillance system. We needed disruptive innovations to improve cardiovascular disease care and strengthening primary care. And we also needed to build a cadre of independent researchers who could carry on the mantle and come up with very bright and smart questions. We needed to synthesize and disseminate information to policymakers and the general public, and we needed to build large-scale collaborations. I'm very, very grateful and thankful to the strong partnership, particularly with Emory and several other partners listed here. So if we have to combat cardiovascular disease on a global scale, what is needed? I think there are two complementary approaches. And if we draw the population distribution curve, we will realize that most of the deaths and disability occur in the middle of the distribution. So you require a population-based approach, and you try to shift the curve a little to the left so that you reduce the risk factor a wee bit in the population, and it can have immense effect because it addresses the bulk of the distribution through small shifts. But at the same time, people who have developed disease or people who have risk factors, we need to cater to them because it addresses the individuals at the highest absolute risk of a cardiovascular event, but it's very, very cost-effective use of resources. So you require both these complementary approaches. So I'm going to talk about 5 themes. And the first theme is that we need to understand the mechanisms of disease because the context is very, very different. And I'm going to give the example of diabetes, which Professor Venkat Narayan and his colleagues have actually advanced and have and are on the threshold of identifying new mechanisms. And this happened partly through this mechanism. So one is, if you have to prevent diseases, the most pivotal thing that is required is to generate epidemiological data for development of guidelines. And for that, you require longitudinal studies. And at that point of time, we had very few cohorts in India. And the NHLBI Center of Excellence grant was a great opportunity to develop that cohort, and that's what we did. And when we started out, these were the individuals who came together, and this collaboration has continued for the last 13 years. And it's one of the great examples of how to collaborate. And Venkat actually pointed out that it's a true partnership. It is Global Health 4.0, where there is equitable partnership, which is resulting in bidirectional benefits, both to an LMIC and to US. And it's unlike in the past where researchers conducted research in developing countries to advance their career. This is extremely different. People like Venkat have been enormously generous in terms of building capacity in countries like ours. So I'm going to talk briefly on this Center for Cardiometabolic Risk Reduction in South Asia, or CARS as we call it. So it's a population-based sample of close to 20,000, 90,000 plus individuals. We have followed them up to around 8+ years. It is representative of the mega cities of North India and South India, and also Karachi in Pakistan. It is a carefully phenotyped and geocoded study population. I'm going to talk about some data from India. We have a large aliquot of sera, plasma, Buffy-coat, and urine stored for future research, and it has helped many young investigators to embed their research in these and apply for new grants. If I have to describe this study, we started off with a baseline survey in 2010, 2011, and again had another repeat cross-sectional survey in 2016, so that this became a dynamic cohort. We added 2 cohorts, and in the interim, every alternate year, we collect data on the deaths, the admissions, and any morbidity that has happened. And the other alternate year, we collect complete data, including bloods and urine, so that we can get true incidence of disease. And indeed, it's a unique cohort in that sense in a LMIC setting. Now, why is this cohort important? And I'm going to use diabetes as an example and look at how this cohort helped. If I ask this audience, or if I ask anybody for that matter, as to why diabetes is so high in many parts of the world, people will say that there's been a substantial lifestyle change. And because of globalization and urbanization, which has led to overweight and obesity, which would result in hyperinsulinemia, insulin resistance, and ultimately result when the pancreas gets, islet cells get tired, you ultimately have diabetes and impaired glucose tolerance. Some people would argue it is the genetic factors and the genes are the ones which are responsible, but others might argue in a genetically predisposed individual, lifestyle change would have caused this. But let's look at an ecological comparison and look at whether this is true across and within populations. This is an ecological comparison based on data from the WHO and the International Diabetes Federation. As you can see here, the overweight and obesity defined by BMI greater than 25 was almost 2/3 of the US population, but the diabetes prevalence at that time was 9%. In China, the BMI overweight and obesity prevalence was 31% and diabetes prevalence was 9%. India had a overweight obesity prevalence of 13% and had diabetes prevalence of 9%. And Japan similarly had a somewhat lower overweight obesity, but had higher diabetes prevalence, higher than all these three countries. So clearly something is happening. BMI obviously cannot explain everything. So one of the argument is, if you're going to look at ecological comparison, there may be other factors. So it's also useful to look at within country comparisons, which Venkat and his colleague Reena was a Frank published. And when you look at this figure, you can see that diabetes prevalence is very high amongst the obese populations, people who originated from the Indian subcontinent. But look at the diabetes prevalence within the so-called normal weight Indian origin individuals, and you will see that it is higher than the obese European origin individuals. Obviously, there is something that is happening amongst Indians. So, in fact, this is not a new thing, because the Lancet did an editorial in 1907 and said, what gout is the nobility of, to the nobility of England, diabetes is to the aristocracy of India. We have lost the aristocracy and the British have left, but diabetes pursues us. Again, coming back to Lisa Steimer's and Venkat's Kelly West lecture, where he outlined this features and did a comparison of Pima Indians and Asian Indians. One remarkable thing is that prevalence of diabetes between Pima Indians and Asian Indians is exactly similar, 50% by the age of 55 years in both the populations. In terms of obesity profile, the Pima Indians are very obese, BMI of more than 33 and waist circumference close to 109 centimeters. The Asian Indians were relatively thinner, BMI of average BMI of around 26 and waist circumference which was much lower than the Pima Indians of around 83 centimeters. In terms of the glucose profile, the Pima Indians had a higher 2-hour plasma glucose as compared to Asian Indians who had a higher fasting plasma glucose. And in terms of pre-diabetes distribution, it was observed that the Pima Indians had higher impaired glucose tolerance as compared to Asian Indians who had a higher fasting glucose. And insulin resistance was 2 to 4 times higher amongst the Pima Indians as compared to Asian Indians, but the insulin secretion was only 1/2 to 1/3 as compared to Pima Indians. Clearly, the mechanisms that was operative in diabetes was different. In fact, when I talk to clinicians in India, they say that one of the most difficult things for them is to control the fasting blood sugar amongst diabetics. So clearly, it is a different mechanism by which diabetes becomes operative in Indians. So this led to a profusion of analysis, and in fact, there are multiple analysis that is going on. We looked at the role of pesticides in the incident type 2 diabetes in India, which did not pan out. Maybe it was underpowered for age interaction, and maybe we require a higher number of years of follow-up as well as more incident diabetes. And a position paper has been published by Venkat and Alka Kanaya from UCSF, which is looking at the role of hepatocytes in the pathogenesis of diabetes. And there are many other things that we could look at. Indeed, it's a very important question, very rich field And there are several factors that we could look at, including organic pollutants and incident diabetes, air pollution and diabetes, which I'm going to talk about air pollution and hypertension, but a similar analysis is being done for air pollution and diabetes. Diabetes and non-alcoholic fatty liver disease. My friend and colleague, Dr. Nikhil Tandon, is looking at the CARS cohort again and looking at the non-alcoholic fatty liver prevalence, and the preliminary analysis suggests that it is extremely high in the Delhi population. The other area of fertile research is beta cell function and capacity, understanding the mechanisms of diabetes, comorbidity, and several others. So clearly, as you can see, this cohort has helped us understand one of the mechanisms and has led to a fruitful research, and maybe the treatment differs. I can just give you an example of how blindly we have been following Western guidelines. If you look at hypertension management for nearly 25 years, the first line therapy for hypertension was a beta blocker. If you look at the South Asian phenotype, the South Asian phenotype is characterized by a high risk for diabetes, high triglyceride levels, low HDL levels, and poor physical activity. What does beta blocker do? It raises triglycerides, it increases the risk for diabetes, it lowers HDL, and it makes you lethargic, it prevents you from exercising. So we have been clearly using this. So therefore, there is a requirement to understand the mechanisms in every context and every culture, and things may be different when you look at them in a disaggregated way. Now, moving on, I'm going to talk about the next collaboration, which actually emerged from the CARS collaboration. And this was, again, an NIH-funded study. It was another program called the Geo Health Program, which was funded by Fogarty, and they have created these 7 centers of Geo Health across the world, and we are one of them, where we are looking at trying to relate air pollution to several cardiovascular risk factors. The main objectives of this network is to look at a robust exposure assessment, that is the air pollution assessment using PM2.5 as the marker at a finer resolution. Currently, what is happening across the world is you have a station, you measure the PM2.5, it covers a radius of 10 to 15 kilometers area. But we wanted a finer resolution at 1 kilometer to 1 kilometer so that we could relate it to the cardiovascular disease in our cohort. It links exposure to cardiovascular risk factors and to link exposure to cardiovascular risk factors and outcomes, and build capacity in the science of air pollution. So in our cohort, we wanted to develop an exposure model to predict daily PM2.5 concentration at a 1 kilometer square spatial resolution for Delhi. So we divided Delhi into 1,635 grids, and over 7 years, every day of those 7 years between 2010 to 2016, which was 2,557 days, we had the value of PM2.5, we had the weather data, we had the wind speed, we had other meteorological data, and we had close to 4.2 million observations. Now we used obtained data for PM2.5 from multiple sources. We used data of pollutants from the 25 stations that were in Delhi, but a large majority of those stations were measuring only PM10. And so we had to use a sophisticated model to convert that PM10 to PM2.5. In terms of other sources, we obtained data from satellite. At least the satellite goes around Delhi twice a day, and we could get the aerosol optical depth from the satellite, which would indirectly give you the PM2.5 level. It also gave the vegetation index. It provided ultraviolet emissions, which can interfere with the PM2.5 levels, and it also gave data on active fires. We use the emission inventories, which are located close to polluting industries, and we obtain data from them. In terms of weather, we had meteorological data to get data on temperature, relative humidity, wind speed, precipitation, so on and so forth. And we also needed to adjust for land use, because green space, parks, the highways, the railroad services, all of these actually determine what is the level of pollution, and we adjusted, we used them for adjusting this data. So we put all of these together, and we used a model called the chemical transport model, and used a machine learning technique called ensemble modeling, and obtained the PM2.5 levels. And these are data from 2010 to 2016 every month for Delhi. And as you can see, as we move towards winter, it's not very clearly visible, but believe me, as we move towards winter, by the month of November, December, and January, you will have a red indicating that very high levels of PM2.5 are there. And as you can see, as you move from 2010 to 2016, the pollution levels increased. The second thing we created was the walkability index in Delhi, and it was based on multiple parameters. And you can see here in this panel that very few green dots are there, which is the place where you were able to walk. And this is part of the central Delhi, the diplomatic area and the offices area, but all other areas, it's highly congested and has very little walkability. The third thing that we noticed was that wherever there was a high traffic density, the blood pressure levels were higher. The bigger dots represent higher blood pressure. It's not hypertension, but higher levels of blood pressure within the normal range. But as you go further away towards the periphery, the blood pressure in our cohort was lower. So putting this all together, we analyzed data from close to 3,300 individuals. In fact, this has been published as of today. It's come online in the journal Hypertension. So close to 3,300 individuals from 2,248 households had 3 blood pressure measurements over 7 years. We looked at the long and short-term exposure to increased particulate matter concentration, and we showed that it was associated with increased blood pressure and risk of developing hypertension in urban India. For every 25 microgram per cubic meter increase of PM 2.5, the blood pressure increased by 3.5 to 5 millimeters of mercury, depending on the BMI. So if we achieve the national ambient air quality standards, which is much liberal than the WHO standards, and it says that we have to have PM 2.5, average PM 2.5 less than 40. Even if we achieve that standard, we can potentially decrease the prevalence of hypertension by 15% in urban Delhi alone. So this again comes to the Jeffrey Rose's hypothesis, who said sick individuals arise from sick populations, and to treat sick populations, you require non-personal policy intervention, and these can have major benefits. The next theme I'm going to talk about is how does low-cost interventions improve outcomes for people? And I'm going to talk about task shifting and task sharing and technology-enabled improved healthcare delivery models and quality improvement program. I'm not going to talk about all of that. I'm going to give one example of a health program which we have scaled up. Many of these trials have been done in collaboration with Emory, some of which has been done with Northwestern and London School of Hygiene and Tropical Medicine. But the pioneer to this was the CARS trial, again funded by NHLBI in the first go. And this had 11 centers, and it was published a few years back. Mo Ali led this study along with Dr. Nikhil Tandon, and there were several other aspects. But to summarize, in all these studies, what was there was we developed a robust electronic decision support system. We provided integrated care. We evaluated a quality improvement program in terms of discharge advice, frequent audit of the care that is provided, looking at management principles, and in fact, team-based care. Again, recently the independent trial was published only last 2-3 days back. And we also looked at some traditional approaches in terms of cardiac rehabilitation. We used yoga as a tool for cardiac rehabilitation. Due to paucity of time, I'm not going to talk about any of these, but I'm going to talk about digital health. In terms of digital health, what was our aim? For the patient, we wanted greater satisfaction amongst the patient because we have these overcrowded OPDs in India. We wanted better access for them. We wanted them to get improved treatment adherence, and we wanted them to have good personalized care. For the provider, we provided a decision support system and an electronic patient or information records. We wanted them to save time and focus on the art of medicine. For the health system, we wanted an improved quality of care. Again, we wanted electronic records for big data analysis and artificial intelligence. What was the process? This was evaluated in multiple settings, starting from the community to the primary to secondary and tertiary care centers. We used multiple methods, including formative research, RCT, and demonstration projects. We had several high-impact publications, and following research demonstration, we scaled it up across 2 states in India. And currently, my colleague, Professor Nikhil Tandon, is evaluating it for a national level scale-up through the ITREX study. We want to make it a sustainable programs, and we're also looking at new areas. In simple terms, I just want to talk about the Empower Heart ML system that we developed, which works on Android and Android platform, as well as works on Windows app. It runs on tabs and desktops. We have actually also started working on the iOS system now. It's useful in terms of screening and management, and it can compute more than 2,500 clinical management scenarios. In the backend, there are 2,500 case studies. It stores patient data in electronic format, and it uses machine learning to come up with a diagnosis as well as advice for a given patient. And so it aids in structured patient evaluation. It can be used by a range of health workers, including nurses, A&Ms, auxiliary nurse midwives, medical officers, care coordinators, and others. So in a simplistic form, this is the pathway which a patient undergoes. When a patient walks into a health facility, the patient is sent to a nurse coordinator if the patient is more than 30 years of age. There's an initial assessment, and details are entered into the Empower decision support system. The medical officer then gets a printout of the recommended action. The medical officer can accept or rewrite. If the medical officer accepts or rewrites the prescription, the patient comes back to the nurse care coordinator, who actually uses the decision support system to provide lifestyle advice. So it saves time for the doctor, as well as somebody is talking to the patient. The patients are extremely satisfied. The patient walks with the prescription. In addition, there are auto texting facilities so that the next appointment that is being scheduled can be sent to the patient as well as to the care coordinator, who can call the patient back for follow-up. And this is one of the reports which shows how longitudinally we can track these patients. This particular patient had a poor blood sugar control, and our decision support system said this is poor control, increase insulin. But the doctor is autonomous. He spoke to the patient and found that the patient had stopped insulin because the patient had gone off somewhere for a wedding or something like that, said, okay, continue with the same and then you come back. But when they looked at blood pressure, the blood pressure was very well controlled, so he agreed with the decision system. As you can see, there is an enormous amount of flexibility for the doctor in this program. I'm not going to get into all the details. It has multiple features, but 2 points I want to make is it adheres to the current internet standards called HLA standards in India. It is interoperable. It can work offline because there is internet instability across the country. It can work offline, and when you get internet, it can dump the data on the server, and you can get real-time data. And there are several features which help in patient care, like the profile visualizer, which I showed you earlier. So once we did the research, found that it is useful. We wanted to see it in real life settings. So we went to the state of Himachal Pradesh, which is to the north of Delhi. And there, over a 21-month period in 6 outpatient clinics, we screened 21,000 patients. That is, anybody above the age of 30 years had to undergo screening with measurement of blood pressure and blood sugar, and the data were entered into the decision support system. We identified close to 6,800 patients. But the important point that I need to make here, that 50% of these patients were detected for the first time. In the conventional system, they would have not been detected, and they would have continued to have diabetes or hypertension. They could have come with complications, and they would have been detected much longer in their natural history of these diseases. The second thing was, all we ensured there was steady simple drugs availability, which were recommended by the National Health Standards, which is called National Public Health Standards. And according to that, simple drugs for hypertension and diabetes had to be available in these centers. And we requested the government that please ensure that these drugs are available. No fancy drugs, no fancy investigations. And as you can see here, within 3 months, there was a substantial decrease in blood pressure, as well as a huge decrease, which came as a surprise for us, in blood sugar. And this was sustained up to 18 months. Once this was done, we scaled it up. So you can see the journey of this electronic decision support system. We started with the CAST trial. We had 2 PhD theses looking at community healthcare center setting. What happens? We looked at a combination of diseases in multiple settings in India: hypertension, diabetes, depression, alcohol, tobacco. Then this platform was implemented across Tripura and Mizoram, 2 small states in the northeast of India, where we looked at added few other diseases, including chronic obstructive cancer. Now it is being evaluated in the ITREC program in the state of Punjab. We also helped the WHO develop an electronic decision support tool to implement their PEN program, which is being used by primary care physicians and community health workers with a range of diseases. Now we are moving into private sector. and we are also developing a symptom-based decision support system. This is a classic example of how research is translated into a big program and policy. Now, moving on, I want to talk on the third theme. If we have to combat diseases like cardiovascular disease or chronic other chronic diseases, we require three things: public health, clinical medicine, and research. And what is at the intersection of all this is capacity building. We need to train people. And that's what we did. There are three areas of capacity building that we did: capacity building of primary care physicians on a big scale, creating public health leaders with a joint program of Emory called the PH Leader Program, and research capacity building. I'm going to briefly talk only about the research capacity building due to paucity of time, but I need to tell the story of others rather than say that we built the capacity. We were phenomenally lucky to have very bright young people who are much, much smarter than older people like me. And we also had the advantage of getting co-mentoring from international researchers like Venkat Narayan, Mo Ali, and several others. And they have become independent researchers in their own areas and developed their own field, and they are conducting their own studies and having their own big grants. So this was the most satisfying and fruitful thing of this global collaboration. The other thing that I want to talk about is that we Indians believe in the ancient philosophy. There is a Sanskrit word for it called Vasudhaiva Kutumbakam, which means the whole world is a family. And there have been several US fellows and scholars who were trained at our center, because our center was named as a Fogarty International Training Center, and as part of the Emory program, the R25 program, and the Vanderbilt program, we get at least 1 to 2 fellows or scholars every year, and we pair them with an Indian researcher, and it has been an extremely fruitful and successful partnership. And I just want to tell the story of 2 trainees who trained in global health at our center. One is my colleague Mark Huffman. He came to India in 2009-2010 as a Fogarty Fellow, and he did this fellowship, and then he applied for the K grant. I think he applied for a K99 and R00 grant, and he was jointly mentored by me and Lloyd Jones and others from Northwestern University. But after finishing that, he established a platform of research called ACS Quick, and there is a big network of research that's happening in Kerala. Now, after that, several people have come in, and he's mentoring them, and the platform is still very, very active. He also started the Emerging Leader Program for the World Heart Federation, and he launched the Institute of Global Health in Northwestern University in 2019. This is the most powerful example of what global collaboration can do. Secondly, I'm going to talk about Kavita Singh, who joined us in 2010, 2011. 2008, she joined us, but became a Fogarty scholar. She was pre-PhD at that time. Following that, she finished a PhD. Then she applied for a K grant jointly under Mark Huffman and my mentorship. And she's another success. But I'm just giving these as 2 examples. There are several other people who have been extremely successful, who trained with us, and have become leaders in their own right. The last but one theme is dissemination, policy, and advocacy, which is extremely important. Earlier, researchers believed that we should have a hands-off approach in terms of policy making because there is a conflict of interest. But now we realize that it's very important for us to actually disseminate. Who better than the researchers who understand what has happened, what can happen, and therefore there are 3 areas where we need to advocate or we need to intervene. One is at the level of policymakers, second is at the level of the population, and third is at the level of the providers. So Venkat alluded to this disease control priorities project, which I co-led with several international leaders, and it had 21 chapters, 68 authors from 15 countries, and there are several chronic disease conditions that were covered. So it looked at a cost effectiveness analysis as to how much health for how much expenditure, and it did what is called as the extended cost effectiveness analysis. That is, how much financial protection does $1 million buy? Before this, people focused on cost effectiveness, but this focused on protection because people not get into poverty, below poverty once they get these acute diseases. The summary of best practices was based on the strength of evidence by function. So we actually had this 2 or 3 different platforms: the delivery platforms for the population, for the community, and for healthcare, And we had by function in terms of promotion and primary prevention, screening and case detection, treatment, care, and rehabilitation. And the interventions that we recommended included fiscal and intersectoral interventions. That is basically, how do we provide universal health coverage to people? How do we fund this universal health coverage? What are the interventions that we can do in a cost effective manner and in a feasible manner? These are some of the questions we asked, and we answered them in this book. It's available in the net free of cost. The other thing is to require rapid, because there should be acceptability for this. To reduce sodium and we have to create awareness. And what better than hypertension? So we use hypertension as an example. Every year from 2017 onwards till 2019, this year we didn't do it. In the month of May, we called that May month measurement. And we used volunteers to create that awareness by measuring blood pressure, giving them leaflets in terms of what needs to be done in terms of hypertension. So in India itself, we had 50 plus participating institutes, 500 screening sites, more than 20,000 healthcare professionals were involved, including medical students, and close to 1 million people were screened. Across the world, close to 4 million people have been screened. So now the global burden of disease feels that this could be a good mechanism for surveillance. It comes at a low cost. And the remarkable thing is the prevalence that we found, the prevalence of month was really similar to big surveillance program. So clearly a low cost program as well as creating awareness has been established. We should not forget the providers, because health sector plays a key role both as a contributor and a mitigator of environmental health, which is emerging as a major contributor to chronic diseases. So we are working on strengthening capacity of research, communications, and advocacy in air pollution. And we also have some preliminary evidence that greening of hospitals improve health outcomes. So we have created a platform called the Health and Environment Leadership Platform, where over 7,300 healthcare institutions of India have signed into this. We also are planning to put in low-cost air pollution monitoring in 94 cities across India, so that we can get data all across India. And we also created this awareness amongst doctors using a study and looking at what is the knowledge and awareness of doctors on the health impacts of air pollution. Do doctors communicate concerns regarding air pollution to their patients? And does air pollution feature as a priority within the health community? Because of our advocacy, many of the national bodies have started featuring air pollution in their conferences. The last thing that we would want to do is look at climate change, because that is also an important component of reason for chronic diseases. And so creating climate smart and climate resilient hospital is an important aspect. Now, as you can see, from research, we moved on to capacity building, moved on to policy making, as well as to creating advocacy for both providers and people. But we cannot stop here. At the future, we need to at the start. What are the new frontiers and innovations? We need from individual to family or group level interventions, and one similar to that. We need some new techniques. We need to develop and evaluate new metrics of measurement, particularly in dietary assessment, which is extremely poor. And we need to use technology for addressing many of the challenges that we face. This is an example. Shivani Patel, who's at Emory, whom all of you know, led this paper on chronic disease concordance within Indian households, which was a cross-section study, which showed that there was strong concordance of chronic conditions within poor residing settings in India. So this was irrespective of the shared genes or environment. Now, given this fact, why do we have to focus on individuals? Why can't we do prevention at the level of a household or a family? And my other colleague, Dr. Jimon, he's got a big grant from Wellcome Trust, and he's precisely looking for this. He's doing a study called Prolific Study, which is based randomized controlled trial in individuals with family history of premature coronary heart disease. And he's actually finishing the analysis, and soon we'll get the results. The other area that requires attention is the food systems, because sustainable development is based on good nutrition and good health, and all the other things like agriculture and environment are interrelated. When we mean by food system, it encompasses everything that we grow on the field to what goes into your mouth. So everything that happens in between is constituted by food system. It's important with medicine at a program food system policies that deliver nutritious and healthy in a sustainable and equitable manner, to diets, and what are the critical components and interactions of the environment in the future. We are in the middle of this grant. It will get completed in 2022. So this is being done in India, South Africa, the countries. We will
I think it looks like Dr. Prabhakaran may have lost his connection.
Huh?
Oh, you're back. Okay, sorry, Dr. Prabhakaran, we lost you for about the last minute or two.
Yeah, I'm coming to the end of my talk. I have just 2-3 slides more. So I'm going to look at the research to policy continuum and look at the pathways. When we talk about research in terms of combating chronic diseases, we require to think of research in 4 different dimensions. We need biomedical research, the epidemiological research that we do, the basic sciences research that we do to ensure credibility of what we are going to tell the policymakers. We need to look at the financial feasibility both through cost effectiveness, as well as extended cost effectiveness. We need people to accept whatever intervention that we are going to give them. So we need social sciences research. And we need to see if the health system is ready to adapt and adopt what findings that we get from research. So we require health systems research. So as you can see, this is the pathway from research to policy. You conduct research through many of these mechanisms. You synthesize this information, disseminate this information both to the policymakers as well as to the general public, and we need to act on the evidence that we have got. And once we have acted at a pilot level, we need to scale this intervention and create a sustainable policy or program. So I asked one of my mentees that what is so important about global cardiovascular research? And he said, we, the global community, will not achieve our collective goals without global cardiovascular research and training, which serve as the dual chamber engine for improvements in public and health and clinical practice to improve population and individual level health. So I just want to thank in French all my collaborators who are listed here, but plead in English for their mercy if I have not acknowledged them. I want to acknowledge my family who have been part of my journey. I have missed many of the important things. They have allowed me to do whatever I want in this journey, and therefore I'm extremely thankful to them. I'm thankful to these people. They made it fun. These are all colleagues from Emory and Northwestern and a few other places. This journey has been made a big fun because of them, and we have been able to succeed. It's not only fun, it was with high science, it was mentoring so many people, and it was really, really fruitful. And this is my extended family that includes all the colleagues with whom I work, my mentors who have taught me a lot of things, and my close friends who figure I told show this slide. So for to this recording, please.
Yeah.
Okay.
Yep.
Oh,
Prabhakar, can you show, we lost your slides, the presentation. Can you show the last slide with the email address?
You want the last slide?
Yeah.
So can you see Mark?
No, I think it's
yeah.
Yeah, why don't you continue the conversation and I'll try to get a slide up.
Prabhakar, if you're finished, we can start. We can open some questions if you're ready.
And Arshad Kayumi has joined us also as a panelist.
I'd like to welcome my colleague Arshad Kayumi, who's the director of the Emory Cardiovascular Disease Institute. So we will pose some questions. There are a number of questions from the audience, but I want to pick a couple of them. Firstly, a question from Abraham Babu. What is your advice to young researchers embarking on cardiovascular disease research? Can you briefly give an answer to that? Prabhakar?
I think we may have lost
I think
Prabhakar.
we lost him.
Yeah. I think it's on his side connection.
Prabhakar?
I lost you in between. So can you ask the question again?
Yeah, there's a number of questions. I'm going to start with Dr. Abraham Babu's question. What is your advice to young researchers embarking on cardiovascular global research? Just briefly, there's a number of questions, so keep your answers brief if you can.
I mean, it's an easy question as well as a little difficult question to answer because it requires a long answer. But there are tremendous opportunities for young researchers. You need to develop your research skills through short-term programs like the International 10-day Seminar for Cardiovascular Epidemiology. You have the World Heart Federation's Emerging Leader programs. We have this short-term training programs through our collaboration with Harvard. And there are several other programs. In addition, there are these long-term for people who are getting into full-time research. You have the Wellcome Trust DVT Alliance grants, which funds you generously in terms of developing your skills. So there are multiple ways of doing it. You can write to me and we can look at it later in detail.
Thank you. So let me give Dr. Kuyumi the opportunity to ask a question or two, and then there are other questions from the audience which I can share with you. Arshad?
Okay, thank you. You can hear me?
Yes.
Yeah,
hopefully.
I can hear you.
Yes. Yeah. Prabhakar, this was just absolutely amazing. I mean, I can't remember when I heard anything so encyclopedic in its breadth and depth, and the work that you are doing and your colleagues, and then condensing it all in this short period of time to take us through your journey. And, you know, so I had like 20 questions written down as you were presenting stuff. So let me just ask you very briefly one. In the Empower study that you have implemented and are doing these screenings and expanding it, you mentioned blood pressure and blood sugar as the kind of fundamental things that you do, but you do anything beyond that, like cholesterol and perhaps even imaging, or is that done in a selective way? How is that expanding?
Right, Dr. Kaimi, thank you for these questions. Our focus was on primary care. At primary care, and we wanted to reach out to as many people as possible. Given the fact that prevalence of hypertension overall in India is around 28% and diabetes is around 10%, we focused on that. But in addition, we added things like quitting tobacco, addressing alcoholism, depression, chronic obstructive lung disease, and lipids also in some of the centers like the CARS trial focused on lipids too. And we have moved on now to look at gestational diabetes and pregnancy-induced hypertension. We are evaluating that in the state of Telangana in a large cluster randomized trial. And we are moving towards creating a symptom-based approach because patients come with symptoms. And from that symptoms, how do we move on to getting their personalized care? And that's one of the things which we are working on.
Right.
I hope I answered the question, but we didn't do imaging.
No, that was great.
Yeah. You know, Prabhakar, there's a couple of questions. You know, the one from Amber Kulshetra. He's asking you, what proportion of Indian patients use allopathic versus Ayurvedic or homeopathic treatment? And are you doing any work in the alternative systems of medicine and its integration into modern medicine?
So I don't have the exact answer to that question. The thing is, we asked in one of our surveys, the urban rural survey, we had a question on if you have hypertension, what treatment do you take? Whether you take Ayurvedic or Ayush treatment or whether you take allopathic treatment. I think at that time, some 5 to 6% of the people said that they were taking Ayurvedic treatment. But for acute illnesses, people actually prefer to take allopathic treatment, and rightly so, I suppose. But Ayurvedic treatment or Ayush treatment, I mean, I won't call it Ayurvedic because it has other components like Siddha and homeopathy and yoga. There is a certain role, particularly for yoga, there's a clear-cut role based on our study that we published in JACC, where we showed that people who actually performed yoga regularly had better outcomes after a heart attack. And we are evaluating this again in a very large trial on heart failure. It has been recently funded. We are going to do a 3,500 patient heart failure study where we are going to actually look at the mechanisms, whether it is renin-angiotensin system related improvements, whether it is atrial dilatation related improvements, or whether it is autonomic nervous system activity related. So that's what mechanistic component is going to be studied. But we're also going to look at the effectiveness of yoga in improving 6-minute walk, quality of life, and mortality and morbidity at the end of 1 year. So that is being done. But I don't have the answer that you're seeking in terms of how many people are using Ayush for chronic diseases.
Yeah, then the next question is from Anuba Agarwal. She asks a very important question. So what do you think may be the greatest challenges to sustainable collaborative global cardiovascular research in the next decade? I mean, she's reflecting from her perspective as a young and upcoming global cardiovascular disease researcher. So what is your advice for sustaining collaborative research into the future?
Again, it's a very important question, but with a very difficult answer. I think worldwide countries are becoming nationalistic, and it's kind of becoming difficult because we are slowly moving away from the feeling that it's a global village to a circumscribed village. That's what is really happening. So it has become little difficult. The regulatory processes have become more stringent. Funding has become difficult for countries like India and others, but there's still a movement towards global health because ultimately mankind requires global solutions. You cannot have solutions in silos. You cannot have the best of care in one particular country and allow the social determinants to determine what happens to the life expectancy of people. And that will result in unrest. So I'm just giving a philosophical answer because there's no real answer. We have to become nimble. We have to become innovative as the regulations become tight. That's all I can say.
Okay, Arshad, any other question from you? Arshad? Okay, there's a question from Matt Durstenfeld. He says, the Empower project sounds amazing. One of the concerns of machine learning and artificial intelligence approaches in the United States is a concern that they may exacerbate disparities. So how do you address that? I mean, so in other words, will e-health, would it narrow or exacerbate disparities in cardiovascular disease outcomes and processes?
So you're looking at ML, you have to look at ML in terms of whether you're talking about patients using the ML platform or the providers using ML platform. In our system, it has been largely targeted towards providers because we just wanted them to, have an improved conversation with the patients. We wanted them to have the data of the patients before they reach the doctor. So clearly it was helpful. But if you're asking whether providing text messages to patients, yes, that would lead to disparities because there are so many factors that determine compliance of patients towards care, their education, the kind of understanding that they have. So to create a solution for that, we are creating something called icon-based solutions where you don't require languages. You just use icons. Even an uneducated person can use that icon. I didn't have the time to project that. One of my colleagues is working on that, and he's in fact talking to people in terms of scaling that up.
Okay, so I wanted just two final questions. One from Satish. Could you provide some thoughts on the impact of COVID-19 on future cardiovascular disease research?
I think the thing is COVID-19 has impacted cardiovascular research as well as cardiovascular disease management currently. But this will come to pass. I mean, COVID-19 is not going to be there in perpetuity. It may take, in the worst case scenario, 2 years, in the best case scenario, maybe 1 year. But things, though there are lots of things that will change, like for having these webinars and teleconsultations and so on and so forth, but we will still continue to have the same focus on cardiovascular disease research. There is a temporary setback. There are people who are unable to access healthcare. Because of that, there's increased mortality. Sicker patients are coming to hospitals. In fact, the CSI is going to publish a study which has looked at mortality last year as compared to mortality this year between July 15th to August 15th. They have recruited 45,000 patients within 1 month period. And so that data will come out soon, and it is suggesting that the number of deaths have gone up because we are getting very sicker patients. But having said that, I don't foresee any major impact in the next, after 3-4 years or so. I may be wrong, but I don't really foresee.
Okay, the next question is from Megha Shah. She asks, when we think of bidirectional research, it seems that methods to improve patient activation vary by culture. So what are your thoughts about how techniques that have been largely tested in Western populations, techniques such as motivational interviewing, how do they translate in LMICs particularly? Are there major differences? How would you adapt them?
So I think each of the cultures have to, the techniques, the ultimate techniques are going to be common. We want to ultimately improve patient compliance, patient coming back to the hospital, taking the treatment correctly, and so on. So, for example, if yoga can perform something very similar to what a motivational interview can do, why not use something which is culturally acceptable? If Tai Chi can do something in China which is similar to yoga, why not use Tai Chi? So I think we need to adapt some of these things to our own cultural context and use them, rather than implement something which was done there in the US. For example, the DCLIP trial is a great example. I mean, you use the DPP thing, but modified it to the local context and conducted the trial and showed that it can benefit. So essentially what I'm trying to say is, while you may have some evidence, we need to contextualize that evidence.
Okay, so there's one other question. What are the, again, similar theme, but what are, again, a little more specific, what are the major challenges one could come across while handling a global research project, especially those which young researchers must be aware of? In other words, what specific advice do you have for young researchers when they embark a career in global health? Other than funding, what else can you think of?
There are lots of challenges. The first challenge is, let us say that you would want to come and work in India or in Africa for 1 or 2 years. The relocation of your family itself is it's a difficult decision to make. The culture is very different, so you will have to adjust to that culture. You will have to think of how to do that. Communication is an issue. Just to give an example, Richard Smith, the former editor of British Medical Journal, sent me one thing about communication. And he said, what do the Britishers say, and what do they think when they say something, and what do other people think? If a Britisher says, oh, your proposition was very interesting, it means that they're really saying that it was horrible. So you need to understand that language. Second is, you need to adjust to the time difference. Like, for example, I have very young researchers who say that I'm available at 12 o'clock in the afternoon for a call with you, which means it's my time at 10:30 or 9:30 at night, and he's not thinking about me. So I think you have to be empathetic to others' needs. You need to look at the cultural context. You need to look at the local culture, the language issues, language barriers, so on and so forth. These are all major challenges.
Okay, so I want to ask the final question before I close this meeting. But before I ask that question, for those of you that want a copy of the recording or a copy of the presentation, there is an email address shown here, which is egdrc@emory.edu. If you send an email to this address, we will be happy to send you a copy of the recording or the presentation, which will become available in a few days. So Prabhakar, a closing question to you. So if you were to reflect on your career as a global cardiovascular disease researcher with a strong base in India, but also tremendous connections worldwide, and if you were to think of, say, 3 big lessons that your own life or career has inspired, that you can share with younger investigators, what would those 3 things be? What will your parting 3 pieces of advice be?
3 pieces of advice in terms of becoming a global researcher, that's what you're asking?
Yes.
Okay. I think the most important one is, don't take yourself very seriously. I think that is the most important feature, because if you take yourself seriously and think that you have all the solutions, then you cannot collaborate. be skeptical about your findings, your research. Run it over, think it over before you talk to others. Second is seek advice. I always sought advice. I have a problem. Even I have a write-up and I'm not sure of what I'm doing. I call up Venkat or write to him. I talk to Mo or I talk to somebody. There is nothing like asking even the silliest question. So I don't hesitate to ask for help when needed. Third is you need to respect boundaries, and that you have to keep it constantly there. I'm just telling the soft skills that are required, because other things will come, because most of the people who are in global health research are very bright young people, and they know the subject, they know what to write and what to do. But where many people fail is in these soft skills. You have to learn how to be empathetic and how to be a people's person, and that I think is an important recipe for success.
So Prabhakar, thank you very much. It's been a great talk and wonderful questions. I want to conclude with a very assertive statement. And that is, I know we are going through this phase of nervousness about nationalism and lack of funding and difficulty with collaboration. But I want to, state a position that the march of history is always forwards, and the forces of history always find a solution. And I believe that the future is globalization and greater global collaboration in science and in education in every sort of way. So those of us in global research need to believe in it, need to take it on. I think if it was easy, we would not be doing this. So I urge all young investigators to fight for it and to be in the game. I think the future is yours. I think there are going to be a lot of more opportunities in the area as we go along. With that optimism, I want to conclude this session. Thank you all once again.